So for today, we have some interesting cases and we have Dr. Mohan Nair and Dr. Kartikeya Bhargav to moderate this session. I would request Dheeraj to put everybody on mute. I request both the moderators to unmute themselves and invite the speakers. Thank you so much.
Thank you, Vanita, and hello, Yash. I think I'll hand it over to Kartikeya to take the meeting on from here and maybe intervene whenever required. Kartikeya, all yours.
Thanks, Dr. Nair. So we have case presentations today, and Dr. KKM Nair and Dr. Deepak Padmanabhan will be presenting. So I think first presentation is by Dr. Deepak Padmanabhan. So I request him to present his case.
Thank you, sir. I thank the IHRS for giving me this opportunity to present some cases on COVID and for quite some time. And we've seen some unusual stuff happening. Most of it is lack of care, delay in care. But there have been certain patients that have presented primarily with arrhythmias that you would normally not easily see. And I'm just trying to present some ECGs and like to have a discussion on what the potential could have been for these arrhythmias. Not too much of it is, rather, none of it is ablation related. It's more the how would you manage it in a situation of COVID and how would you go ahead in that. This is over the last 4 to 6 months that these cases have been pulled out, and they've been tried to represent absence of florid COVID, somebody just walking in. Does it show any kind of clue? Is there any way we can suspect it, and so on and so forth? I would welcome both my moderators and everybody else on this group to make it into a discussion rather than a unilateral didactic presentation. I'm pretty sure that all the senior members on this group have seen all these arrhythmias before, but I'm just trying to see if there is a link or a thread that we can have with COVID and the potential myocarditis that it might cause. The background, we were, for a very large point of time in emergency situations, were using RAT to rule out COVID in emergency situations. RT-PCR has to confirm the presence or absence of COVID. And at our center, we ended up using RT-PCR prior to every procedure. So these in situations otherwise presented and would not have been associated with COVID or any other arrhythmia if we had not thought about it. All patients were RAT negative at the time of presentation. So we already know COVID arrhythmias in COVID are mainly decompensations of previously stable arrhythmic conditions is very common. For example, recurrence of VT, AF on medications in the past, perhaps because of either lack of medication, because of non-compliance, therefore, or myocarditis, which is common in COVID as an inciting factor. Towards the end of my talk, I'll come to an important point why I think myocarditis is an important the initiation of arrhythmias in COVID, and perhaps coronary artery involvement also in people who are relatively young, and therefore leading to arrhythmias which otherwise would not have been seen in this population. And maybe perhaps unusual presentations are always there, ECGs which we may not have seen otherwise, perhaps we'll be seeing in this situation. So let's just go right into case number 1, where we had a 13-year-old patient. This was somewhere in March, April, who was diagnosed outside to be a case of so-called tachycardia bradycardia syndrome. Recent onset palpitations were also present. However, there was no loss of consciousness. Again, a 13-year-old patient, tachybrady, unusual, very skeptical. So Holter, which was there previously with the patient, we kind of brought it out. This was their basis of saying probably that it was a bradycardia syndrome, AV block also. They said, okay, fine. Key findings on these two tracings are a PR interval that is relatively long, seems broad inverted T waves and perhaps a borderline QT interval in terms of prolongation. But on this, in an awake state again, there was another tracing that showed the drop of this P wave. The PR remains similar to what was there previously, but this P wave seemed to drop and then go ahead with the same kind of P to QRS to QT relationship, so on. This was another ECG taken at our center. Again, you see slightly shorter PR, perhaps prolonging. With the calipers, I could not see any prolongation. And then a small sinus pause. Not really sure what it was. And we were wondering what's going on in terms of the PR kind of changing from what it was previously to what it is. And then we got lucky by getting this. As you can see, it's a narrow complex arrhythmia, fairly right bundle branch block or right bundle branch bundleoid morphology. Any P waves prominently, even in AVR, not really able to make it out, and very regular, no problems. But this QRS morphology here and this QRS morphology here, the concept of perhaps an automatic arrhythmia arising from the AV junction, that kind of led to the PR prolongation. Additional review at this point of time, whether we would go for medications, put in a PPI or put in an ablation. We were convinced that a PPI was not the way to go and perhaps wanted to do an EP study and look at ablation. RAT was negative at presentation and we were not thinking of medications. Oops, sorry. We got this ECG prior to presentation again, prior to the proposed EP study. And as was our want, we sent an RT-PCR out to see what was going on. It ended up that the RT-PCR was positive for COVID. Troponins were elevated. It was a normal ejection fraction of the structurally normal heart, normal chest X-ray, normal SpO2. So again, the question, whether ablate this patient, take him for an EP study versus give some medications. We did want to definitely figure out whether there was any underlying infrahisian conduction disease. So decided to give some flecainide specifically. I know flecainide is contraindicated, but then given that there was AV nodal arrhythmia, which we were suspecting, perhaps with some automaticity there, we decided to see if flecainide would actually suppress all of it. And it actually did. Flecainide actually suppressed all of it. The LV function did not worsen. The blocks did not. And over a period of time, this patient was kept on continuous monitoring, including remote monitoring. The PR kind of settled down, no further such episodes. And despite the myocarditis, we were able to manage this arrhythmia. So I would like at this point of time, given that. The block obviously is similar to a paroxysmal AV block. The AV was not really bad. It was probably the firing of the junction that was causing the paroxysmal AV block, thereby leading to this abnormal rhythm or abnormal AV conduction. Sir, any thoughts on this at this time?
Yeah, I'm sure this is something which, again, as I said in the beginning, this is a disease we are just learning to understand, trying to understand and learning every day. My own sense is that what has been striking has been a lot of bradyarrhythmias. And in this COVID era, increasingly, we have been very careful about going in for a device for bradyarrhythmias. And some of those patients who have tested positive over a longer period, like an inferior MI we've always discussed, you just observe for a longer period and the bradyarrhythmia seems to settle. So that's my feeling. Regarding rushing for an EP study in this patient, I really don't see an indication. And on a 13-year-old girl with just one arrhythmia with background blocks. So I don't know what is the experience of the others regarding arrhythmias during COVID and which is possibly COVID related, because anything that you see these days, and again, I'm saying that I have been changing my own impressions every week, whether it's coincidental COVID positive or COVID related disease or COVID complicating another already present disease. This is something that's a big mixture, but there is something that's happening. what we are seeing as arrhythmias and like you rightly said, in terms of ischemic heart disease during the COVID period is slightly distinctly different from what we saw when there was no COVID.
Absolutely. Absolutely. We also did, I mean, for all our patients, we always sent a trop as well as try to look for any myocarditis if possible. And trops have come back positive in her, probably suggestive that there is some element of muscle involvement with the RT-PCR, suggesting that perhaps the myocarditis was the cause of it.
But what Deepak, I mean, I'm just saying, I could understand in your slide, if you said, if I think Yash is having the same question.
Yeah.
I can understand if that said that EP study query, just to understand what's happening. But ablation, I really don't know how it came into your mind.
So we wanted to actually find out what was going on.
So that's an EP study, right?
Yes, absolutely. Not ablating it.
Yeah.
Yeah,
Not
but,
ablating. Not ablating. Sorry.
but even EP study, I don't think so it's the right choice in the COVID positive patient, because we don't know. So we have been seeing AV block sinus bradycardia very commonly.
Right.
And the ECG that you showed as junctional firing, it could very well be a sinus tachycardia with marked first degree AV block, because you have other ECGs with marked first degree AV block. So I don't think
I agree with Karthik. Sorry, Karthik, I was going to say the same thing.
Yes.
If you look at these T waves here, they are quite peaked in this ECG. And this very much looks like a sinus tachycardia with a prolonged PR interval.
Yeah. The PR interval, though, sir, kept changing across the course of the stay in the hospital. The PR interval which she presented with compared to the PR interval across this slide, and the PR interval, assuming that the P is embedded within the T here, those were distinctly different. That is what junctional focus scoring a paroxysmal AV block, and this was by perchance an ECG that actually showed us that. This was the ECG after the yes, sir.
Yeah, the other comment is regarding use of flecainide. I think I will be very reluctant with knowing that COVID is prone to cause arrhythmias and sudden cardiac death in a known patient who has possible myocarditis and relatively asymptomatic arrhythmias. I would definitely not like to treat, especially with drugs like flecainide. I don't know what Dr. Nair thinks or Dr. Yash, but I would be quite reluctant. Maybe
Agreed.
if at all need be, a small dose of beta blocker may have been a safer choice.
Yeah,
sure.
I entirely agree with you. I think with the kind of rates and a young patient that you are seeing, wait and watch would be a much safer option than putting in antiarrhythmics. And it is a pattern that kind of fits into what I was saying, that, other myocarditis that you see during a viral epidemic or toxic myocarditis, they're present with, by and large, I'm not saying exclusively, but tachyarrhythmias. But this predominance of bradyarrhythmias with AV blocks, etc., good feature.
Perhaps
I request everybody to put their mics on mute, please. Whoever is joining in, kindly put your mics on mute. You are disturbing the entire discussion.
Well, somebody muted me actually, so it's okay. So that is my comment. I don't know, Dr. Vanitha, you've been seeing a lot of patients.
May I make a comment?
Right.
May I make a comment?
Sure.
Behzad Pavri and his group have published a paper
on the PR interval.
Normally with sinus tachycardia, physiologic sinus tachycardia, not like the one, but in COVID, they have published a paper that the PR doesn't behave that way. It doesn't shorten in COVID like it does with other sinus tachycardias. I think that itself tells us that the AV node is having, some affection in COVID.
Absolutely.
Okay, I think you can move on.
Yeah, going on from that explain COVID, here we came to a second case. So 36-year-old male presenting with complaints of dizziness, no chest pain. This was the ECG at the time of presentation. This was all that we had. Referred in from outside tried initially and then sent to our center with a temporary in place. Temporary wasn't capturing well, didn't want to do a permanent pacemaker in someone with COVID who was so young. Decided to put in a temporary permanent. He also had elevated function by transthoracic echo. The RT-PCR was positive. This was implantation of a temporary permanent without worry of dislodgement. Day 7, he started recovering his conduction. There was intermittent paced beats, but then the conduction started recovering. And here we were kind of concerned about this ST elevation, as you can see in V1. None of the other leads show corresponding ST depressions, although inferior leads show some flattening, and there was no other changes. As we went on, the conduction started improving, and the patient turned out to be one of those persistently positive RT-PCR patients. So nobody was ready to take him up for anything else. No chest pain still, recovering conduction, still concerned a touch about V1, where there's a slightly upward elevated segment with cooing. Day 21, this was the ECG. Routine rhythm, A to V conduction 1:1, fully recovered. This cooing still bothered us. Decided to do a TMT because the patient was absolutely asymptomatic, even if there was normal rhythm. Normal AV conduction, even at peak, done for 24 hours, did not show evidence of any abnormal conduction, even with routine activity of the patient. We were still concerned that it was a young man, so decided to perform an MRI prior to discharge to just see if there was any evidence of myocarditis that would have settled in so far. And this was the findings of the MRI. There was a basal and mid segment infarction, subendocardial infarction near the base again, and a lot of tissue edema. According to the radiologist, this was evidence of recanalized vessels and perhaps a thrombotic lesion, which has since then improved. Again, bringing into perspective the fact that there was that cooing, which was very suspicious. And obviously, we didn't go ahead with any kind of angiogram at this point of time. We managed him conservatively without a PPI, of course, with antithrombotics, antiplatelets. 40-day on follow-up, he's asymptomatic, planning to bring him back later for an evaluation for his coronaries. Any thoughts right now, sir, about whether we should have gone ahead or waited? How should we have approached it? Again, panel open for discussion. Definitely point out stuff, sir.
I think so. Your strategy was correct. There's no need to rush in for an angio or any device implantation at this stage. And we know there is evidence of myocarditis. Even those ST changes in V1 could also well be because of myocarditis. So I agree. I don't think we need to rush in. Most likely, we will not need any procedure later as well.
Yeah, but to be frank, we have ended up burning our fingers at least 1 or 2 cases where the ST changes were far more telltale, But having burned our fingers, those are again, these 40-year-olds, borderline age groups with some atypical chest discomfort, ST being up, you do an angiogram, and then you see that it's is now what is increasingly being reported as thrombotic complications towards the end of week 2. So we've pulled back, and like Kartikeya is saying, we are very, very careful and in the COVID data for rushing into an angiogram. Honestly, it's wait and watch, which seems to be the best. I don't know. And there seems to be very little. If you remember from Italy and Spain in the initial stage when there were waves there, they were wondering where the MIs had gone and how the sudden cardiac deaths were presenting, etc. So there is a phase where everybody seems to be a little confused about how to deal with this and how to correlate the pathophysiology. But I think that what I would agree, having seen some of these cases, and I'm sure the panel would, the rest of the people would like to comment, it seems best that if there is a RT-PCR positive, to wait and watch policy as much as possible seems to be the way to go.
Absolutely. Absolutely.
Was there any chance of a lead perforation?
Not really, ma'am. It wasn't. I mean, the echoes were done continuously, and the lead perforation was actually present with the pericardial effusion simultaneously, and not on the septal side. You would imagine a lead perforation to be on the free wall or near the apex.
No. You can have an MI with a lead perforation, and this could have been myocarditis, and the ST elevation could have been because of some hidden lead perforation. But if you had already looked, no problem. It's because of MI.
I probably don't think that was the case. It could happen.
Can I make a comment?
Sure, Dr. Yash.
Sorry, sir.
See, actually, we have had this repeated discussion with our radiologists. Somehow, radiologists by training, the moment they see transmural enhancement, to them it is MI, or subendocardial enhancement is MI, and mid-myocardial is myocarditis. And n number of times we've had young patients with either ARVC or something else or myocarditis, and just because they see the subendocardial enhancement, they say this is MI, this is coronary artery disease. And we try to tell them this patient is not coronary artery disease. You need to reorient your thinking as radiologists. Everything is not black and white, that subendocardial or transmural is coronary artery disease. I don't know what is the experience with your radiologists, but some of our radiologists, their training is such. Now, in light of this case, just because there is a transmural enhancement, that is why your radiologist said this is coronary artery disease. Because this may well be, see, coronary artery disease causing AV block and LAD, especially if you talk of coving in V1, is typically an intra-his block. Now, agreed, intra-his block can have a wide QRS, but this AV block may have nothing to do with coronary artery involvement. It may have to do with primary myocardial involvement.
Absolutely.
Absolutely. Agree.
So, Deepak, there are a couple of questions. One, Vanita wants to know whether we should be starting antiplatelets and or anticoagulation in all COVID positive patients with arrhythmia. And the other question is, do you have any sense about the mortality rate among COVID patients presenting with cardiac manifestation? So do you have any analysis from your center on these two, or what is your policy?
Not right now, sir. We are putting together data. We've been part of a couple of consortiums so far. We are pulling together our data to get a sense of how many of them are doing badly. But from an electrophysiology point of view, where we deal with mostly, we haven't had that worry. We've had plenty of storms present, at least 4 of them that I recall. All of them managed conservatively with the typical management, as Dr. Yash would say, make sure they sleep well, make sure their sympathetics are not working very well, overworking in fact. Now all of them have settled down, luckily. But having said that, our bradyarrhythmias are where we struggle a lot, because to be able to temporize when you want to do the pacemaker, whether it's related to the COVID, how much of it is actually going to recover, it kind of puts a lot of pressure onto the system. And so what we've been trying to do is trying to perhaps use troponins as an indicator for myocarditis to say that, look, this is probably related to the myocarditis if it is RT-PCR positive, versus this is not related to the myocarditis. This may just be an association or a coexisting factor to a degenerative heart block. So that is what we are trying. And Madam pointed out a very important thing, which perhaps we haven't really considered too much, is the use of active fixation, temporary permanent pacemakers in patients with myocarditis. How much of that could actually cause a problem? I don't really have a sense. Regarding the medications that Dr. Vanita asked, personally, I tend to think that if you're having myocardial involvement, it's just severe disease there too. It's not only for the lungs that you need to give steroids as a protection agent. If your heart is involved, and we've seen that previously with tuberculosis, perhaps with sarcoidosis too, the steroids may help heal that. So in the absence of severe requirement of ventilation, perhaps a low dose of steroids can help settle some of the myocardial edema, which is very well seen in this region. So that was going to be one of the questions I was going to have in the case to come. But yes, anticoagulation I would probably prefer for a period of about 30 days, and steroids plus or minus. We'll definitely discuss that more in the case to come.
See, there's a hospital near where I work now. which deals only with COVID. I think as a routine thing, they are giving Clexane for 7 days to all COVID patients who are admitted there. But I don't know what is their criteria for choosing it.
Any of
Yeah,
our panel
I
has
think
this
you have a good point. Across the board, most people have been lowering the threshold for using antithrombotics, that is low molecular weight heparins, etc. And also, like Deepak just said, the threshold for early use of steroids seems to be something that's coming out. Now, the data is not so robust, it cannot be. But I think that a lot of people who are just looking at COVID patients and not cardiologists who are called in to give their opinion are, at least in my sense, the ICU people that I speak to, they are decreasing their time. They want to start steroids early rather than late. So I don't know what is the practice in overall.
In our hospital, practice is a little different. So the anticoagulants, low molecular weight heparin is actually initiated in most patients who are admitted, and especially if their D dimer is high. But regarding steroids, there is a thought that if we start it early, it hampers the fight against the virus and resolution of the viral load. But the important point is that the timing of initiation of steroids is important, and it is mainly required for the cytokine storm and immune mediated damage, which usually happens at 7 to 10 days in most patients. So that is important. If you start it early, it may be more harmful rather than useful. That's what the thinking in our hospital is. And the guiding is by the CRP levels, uh, and especially if the patient develops fever at even at 7 or 8 days, that means that is not because of the viremia, but likely because of immune mediated and cytokine mediated reactions. And then it is very important to start steroids promptly.
Another question that I had was, do we consider cardiac involvement in the form of arrhythmias, in the form of blocks, as significant end organ involvement, severe enough to cause or need to start steroids? What would the panel think about it?
So as Dr. Nayak has put it, most admitted patients receive low molecular weight heparin. If higher D dimer or CRP, it is followed by long-term oral anticoagulation. They use apixaban, we may be using rivaroxaban, and steroids only if persistent fever, high CRP, or raised interleukin 6 levels. So that's what the practice is at our center also.
Perfect. Just go on to the next case. Similar kind of situation, 56-year-old male presenting with history of sudden onset dizziness, episodic, associated with palpitations lasting for 30 seconds to 1 minute. We were lucky enough to get an ECG at the time of this event, and this was the ECG at that time. He was symptomatic with this kind of an arrhythmia. Again, more or less very sharp initial deflections, slight variation in the exits, perhaps suggestive of fascicular involvement exiting at various locations within the left ventricular cavity, suggestive of fascicular involvement. Again, suspicion by this time, this was about a month ago, suspicion by this time, even in the absence of fever, in the absence of any routine constitutional symptoms, was, this is funny, we don't see this very often, let's send a COVID and send a trop panel. Again, echo was normal, mild MR was present, RT-PCR positive, elevated troponins. This time we got a little bit wiser, decided to give him beta blockers, everything subsided. But the moot point here again is, now that you have evidence of myocarditis, would you want to give in steroids? Would you want to put in steroids at this point? Or would you just be happy with the beta blockers and not worry about it? These are fascicular arrhythmias, again presenting with varying exits, long runs, although suppressed with the help of beta blockers. Do you think these would be markers for us to initiate any other medications?
Well, I don't think there is there would be a uniform guideline or agreement. But as I said, the more I speak to, even yesterday I was discussing with some internists and ICU people, I think that the threshold for starting steroids seems to be going down, and there seems to be a sense, at least in the environment that I work, to be using steroids early than late. So I would think that in our system, if this patient would have been on steroids, I really don't know whether this is backed by strong scientific or robust scientific data.
I think I'll agree. We don't have much data, and the practice is different at different places with the lack of evidence that we have. And so it is going to be an individualized treatment as of now.
So there's some comments. However, at least 3 days of Yash says 3 days of methylprednisolone or dexamethasone. Dr. Yadave says coming out from anterior papillary muscle. Yeah, that's okay, but yes to steroids, says Ajay Naik. So I think it's honestly, maybe the IHRS should start collating data and put in a position statement, on some kind of a consensus on, because we are all agreeing that we are seeing these things which don't fit in anywhere. And the moment it doesn't fit in, increasingly, at least I'm getting confident that this is a COVID patient. And, so
Exactly.
whether we should have some of these very important questions that have been raised, the timing of antithrombotics, use of antiplatelet agents, long-term anticoagulations, and timing of beta blockers, and of course, the proper way to manage these arrhythmias. I think that's something that we are learning, but seems to be, at least in terms of final destination treatment, most of them seem to be doing well as they recover. So there's no need to go rush in for a device or a procedure. That's my feeling. I mean, for sure. But you could be wrong in a couple of patients, that, and I don't know which ones should you follow up more. For example, you have a patient with a scar on the MRI. Would you follow a little more closely, do a repeat MRI and see the resolution of scar? Because the scar is not a very nice thing to have on MRI. So I don't know. These are unanswered questions. But by and large, a more conservative approach seems to be the way to go.
We've just set up an IRB for a MRI based study. We are taking all the patients, all the health staff who have had COVID and have not had COVID, and we are trying to kind of just take a look at 2 months out as to what their MRIs look once you've had COVID. The ones who've not had COVID without any other comorbidities, we are trying to use them as controls. So do let us know if anybody else is kind of willing to partner. I'll definitely be happy to have more on the board. I think it's something that is very interesting and fascinating to all of us, especially in light of Dr. Hygreave Rao's paper previously. Probably this would come into non-ischemic cardiomyopathy. And what does that scar period of time? We have absolutely. Thank you for that insight, sir. So coming to my last case again, relatively straightforward, probably 8 days ago, 21-year-old patient presenting with complaint of palpitations, no previous history of any illness, no history of fever, shortness of breath, RAT negative. And this is her ECG. Sorry, I was not able to get the markers right, but this is V1 for this patient, this being AVF and this being lead 1. Again, looking at relatively narrow complex tachycardia, not typically narrow, 1:1 V2A conduction right here, no AV dissociation, probably an fascicular arrhythmia as far as I go, could be wrong, terminated with adenosine, and presented to us in this manner with this ECG. RT-PCR, as usual, because of the potential involvement of fascicle, we thought it was probably a myocarditis presenting in this lady, never had a previous event, RT-PCR positive, troponins elevated, echo normal with mild mitral regurgitation. That's a finding we are seeing quite often at very early stages when we've not seen any other abnormality on the echo. Have given verapamil for the arrhythmia patient still awaiting recovery from COVID. At this point of time, we plan for conservative management. If any further events happen in the future, perhaps ablation may be considered. but that's a moot point at this point. Just wanted to again highlight the point that perhaps involvement of fascicles, just like as we think for sarcoid conduction system, uh, basal exits or exits within the LV cavity suggestive of fascicular involvement. The thought of myocarditis seems to be pretty much high on our radar at this point in time. And COVID being the commonest myocarditis going around right now, probably something that we are looking at very, very closely. Anybody else has similar cases? We would love to kind of put together a series on them and try to see how these patients did over a long period of time. Going ahead, this is a peek into the future. As I mentioned at the IHRS consortium, IHRS meeting, we are a part of the Discovery Consortium, which basically says that, based on the hypothesis that autopsies all across the board for COVID seem to show inflammatory changes in the heart, even in animal model experiments, and there were significant cardiac complications of COVID-19 with cardiac injury, which was significant. So what we've been able to do in the Discovery Consortium is across the globe, we've been able to kind of partner with a lot of centers and look at ECGs as a baseline in the form of an XML format and use that ECG to see if we can diagnose COVID infection. So this is our aim, to have an inexpensive 15-second screen for COVID-19. I'm happy to say that we've completed enrolling and the initial results look extremely positive, especially negative predictive value. A manuscript is being prepared on that, and hopefully we shall go to publication soon. We at Jayadeva, we've been a part of this trial, and there is a prospective trial based on this algorithm which is coming up, and I would just like to mention it to the group that if there is an opportunity for any of you at any of your centers to partner in this, this would be an incredible opportunity. Once again, thank you for this opportunity to present these arrhythmias in front of you and be able to pick your minds. In summary, I would just like to say that primary cardiac involvement without chest X-ray involvement, any other abnormality, is not unusual for patients with COVID. But more commonly in the younger patients, it seems to be a form of myocarditis which presents with arrhythmias. Recent unexplained conduction tissue involvement is suspicious, especially in us, at least at our center where we are thinking more of a myocarditis here. Prodromal symptoms may not be present. RT-PCR for now remains the bedrock for diagnosis. Definite temporization of PPI in the absence of an alternative diagnosis is what we are looking at, especially if the troponins are not even elevated. And the AI-enabled ECD-based diagnosis is what we look forward to come in the future and perhaps help us to be able to diagnose this rhythm. Once again, thank you, sir, for this opportunity to present before you. It's an honor, actually. Thank you.
Yeah, very well done, Deepak. And I think some of the points are very well taken. I have a feeling, and I think Yash
Very interesting.
Yash and Dr. Vanita can actually maybe put it together. But a lot of these centers, now that we are seeing not hundreds but thousands of these patients, are trying to see if there's anything that we can make out of this, what appeared to be a sense of madness in the beginning. And I think it's extremely brilliant for you to try and use deep learning of the ECGs at admission and as they go along in the hospital to predict events. And that's absolutely brilliant idea. I'm sure Yash would like to take it up on behalf of IHRS.
While you were discussing the cases, Dr. Nair, Dr. Yash has already given the consent on the chat box. If you read that, he's already 2 steps ahead of all of us. So he has, Deepak, you have been put in charge. You are going to be writing that. And by the end of 2020, probably we'll have a consensus statement, kind of thing. He will be coordinating with everybody. I'll discuss with him after this session, of course. So please go ahead.
Thank you once again. This Discovery Consortium is open to everybody. It's a initiative by Dr. Friedman at Mayo Clinic, and they are looking forward to centers participating in their prospective trial. It was a challenge initially for us to get ECGs at the peak of COVID in May. And thanks to all my teachers and mentors here at Jayadeva that we were able to do what we were able to do. 25 centers across the world have contributed to it for about 25,000 ECGs in digital format for COVID positivity. Thank you once again for this opportunity.
Great work, Deepak. So I think we should move ahead. we have Dr. Krishna Kumar, Mohan and Nair to present his cases. So, Dr. Nair.
Is my screen visible?
Yes.
Good evening, all. At the outset, I would like to express my sincere gratitude to IHRS, Dr. Yesh sir and Dr. Vanitha madam for giving me another opportunity to make a presentation in this prestigious platform. I will be presenting a few interesting EP traces most of us would have come across at some point of EP practice. With the permission of the moderators, Dr. Mohan sir and Dr. Karthikeya sir, I would like to start my presentation. Actually, I am very much scared of this presentation. Please excuse me for my mistakes. So, LBB tachycardia essentially comprises of three entities. One is SVT with LBB aberrancy. The second one is pre-excited tachycardia, and third one is ventricular tachycardia. Pre-excited tachycardia can be antidromic reentry, diodromic reentry, as well as SVT with bystander pathway activation. And we know that clear-cut AV dissociation favors VT and negative HV interval rules out SVT with aberrancy. But diagnostic dilemma happens when there is no discernible His electrogram and where there is one-to-one AV relation. Atrial pacing maneuvers can be of great help in those situations. Now let us examine a few cases. So coming to case one, a 55-year-old lady was reported to have a narrow complex tachycardia that was terminated with intravenous adenosine. 12 DCG was normal during sinus rhythm. EP studies showed a normal AH and HV intervals. Ventricular pacing showed concentric activation of the atria with a non-decremental conduction. Atrial pacing reproducibly induced a regular broad complex as well as narrow QRS tachycardias. Coming to the EP trace, there is a LBBB tachycardia on the left side of the panel with a one-to-one AV relation, positive HV interval with a tachycardia cycle length of 315 milliseconds, septal VA interval of 130 milliseconds, and concentric atrial activation pattern with earliest atrial electrogram recorded at CS910 dipoles placed at the CS os region. There is a narrow QRS tachycardia on the right side of the panel with identical tachycardia cycle length, identical septal VA interval, and identical atrial activation pattern as that of the LBBB tachycardia. Then three premature ventricular contractions occurred spontaneously during the LBBB tachycardia. The first PVC has LBBB morphology and is more likely from the right ventricle. It has advanced the atrial electrogram with the same atrial activation pattern without affecting the HH interval, confirming the mechanism as AV reentry. During the LBB tachycardia, the His electrogram was clearly discernible, which has aided in the diagnosis. So this happened to be a case of orthodromic AV reentry involving right-sided concealed bypass tract with the LBBB aberrancy. Now coming to case 2, a 70-year-old gentleman was reported to have an LBBB tachycardia that was not terminated with intravenous adenosine. Here 12 DCG was normal during sinus rhythm. EP study showed normal AH and HV intervals. Ventricular pacing here showed concentric activation of the atria with a decremental conduction. Atrial pacing
The slides are not moving.
Atrial pacing reproducibly induced a regular LBBB tachycardia. Now coming to the EP trace, there is LBBB tachycardia with a one-to-one AV relation. There is no discernible His electrogram during the tachycardia, and an atrial extra was delivered to decipher the mechanism. The atrial extra has resulted in advancement of the ventricular EGM without any change in the QRS morphology, thereby excluding ventricular tachycardia. The ventricular advancement following the atrial extra was preceded by advancement of the atrial electrogram in the His region or the septal A interval, suggesting that anterograde conduction has happened through the AV node, thereby excluding pre-excited tachycardia. The VA interval prior and VA interval after the atrial extra are different, which suggest absence of VA linking, thereby excluding AVNRT as well as AVRT. This happened to be a case of atrial tachycardia with the LBBB aberrancy. Now coming to case 3. Case 3 is a 45-year-old lady who was reported to have an LBBB tachycardia that was terminated with the intravenous adenosine. Tolli ECG was normal during sinus rhythm. EP study showed normal AH and HV intervals during sinus rhythm. Catheter manipulation induced an LBBB tachycardia, and atrial extra was delivered during the tachycardia. This is the first EP trace. There is an LBBB tachycardia with a 1-to-1 AV relation and a negative HV interval, which essentially excludes an SVT with aberrancy. The ventricular activation pattern is distinct in the sense that the RV apical activation is preceding the basal His activation. Now, in response to the relatively early atrial extra delivered from the RA free wall, the LBBB tachycardia got terminated without affecting the HH interval, the VV interval, or the QRS morphology, thereby excluding ventricular tachycardia. Now, coming to the another EP trace. Another atrial extra was delivered from the RA free wall at a lesser prematurity. This has resulted in advancement of the ventricular electrogram without any change in the QRS morphology or affecting the septal AA interval. It then resets the tachycardia with the same atrial activation pattern, thereby confirming the mechanism as a pre-excited tachycardia with active participation of antigradally conducting bypass tract. Now coming to EP trace of the same patient, this actually shows the initiation of the LBBB tachycardia following programmed ventricular stimulation. The PPA minus TCL was 40 milliseconds, which practically excludes an AVNRT with the bystander pathway activation. The AV by AA interval index during the tachycardia was 0.55, suggesting involvement of a slowly conducting bypass tract. So considering all the aspects, LBBB tachycardia, negative HV interval, a distinct ventricular activation pattern, a response to atrial extra of waning prematurity from the RA free wall, distinct response on initiation of tachycardia with a ventricular extra stimulus, and the AV by A interval index suggesting slow conduction. This happened to be a case of atriovesicular reentrant tachycardia. Now coming to case 4, it's a 23-year-old gentleman who was reported to have an LBBB tachycardia that was not terminated with the intravenous adenosine. Tolli ECG was normal during sinus rhythm. EP study showed normal AH and HV intervals during sinus rhythm. Coming to the EP trace, the LBBB tachycardia had left axis deviation and 1-to-1 AV relation and a negative HV interval, which essentially excludes SVT with aberrancy. Throughout the tachycardia, the ventricular electrogram at the RV apex was preceding the His electrogram. The atrial activation sequence during the LBBB tachycardia was eccentric, with the earliest atrial electrogram recorded at the coronary sinus 5-6 dipoles placed 2 centimeters inside the coronary sinus. This trace shows the response of the LBBB tachycardia to atrial extra stimulus. The atrial extra is actually advancing the ventricular electrogram without affecting not only the septal AA interval, but also the QRS morphology, essentially excluding VT, where we anticipate a change in the QRS morphology. Now, it was therefore apparent that the antegrade conduction during tachycardia was bypass tract mediated. After the advanced ventricular electrogram, subsequent to the delivery of the atrial extra, there was a resetting of the tachycardia with the same atrial activation pattern, same eccentric atrial activation pattern, confirming active involvement of the bypass tract. Not only that, the AV interval during the LBBB tachycardia was more than 50% of the A interval, indicating slow conduction of the antegradially conducting bypass tract. All these observations made here are consistent with the antidromic re-entry involving atriovascular bypass tract. Now coming to the next slide. A ventricular extra stimulus is delivered from the RV apex to ascertain the retrograde limb of the tachycardia circuit. Subsequent to that, there is advancement of the atrial electrogram with identical eccentric atrial activation pattern and without affecting the HH signal or HH interval, confirming that the retrograde arm is also a bypass tract. Hence, both arms of the tachycardia circuits are bypass tract, confirming to be a duodromic re-entrant tachycardia. This slide actually shows a narrow QRS tachycardia, which was also induced in the EP lab. The narrow QRS tachycardia exhibited identical eccentric atrial activation pattern as that of the LBB tachycardia. The mechanism was confirmed to be due to orthotromic AV re-entry with the administration of its refractory PVC. So this happened to be a case of duodromic re-entrant tachycardia. Now coming to case 5, a 45-year-old lady was reported to have an LBBB tachycardia that was terminated with the intravenous amiodarone. Total ECG was normal during sinus rhythm. There was no structural heart disease by echocardiogram. EP study showed normal AH and HV intervals during sinus rhythm. There was neither manifest pre-excitation on incremental atrial pacing or dual AV node physiology. Ventricular pacing induced an LBBB tachycardia. Coming to this next slide, the LBBB tachycardia, which is on the right side of the panel, has left axis deviation, V6 transition, and one-to-one AV relation. Unfortunately, there is no His electrogram which is discernible. To understand the mechanism, an atrial overdrive pacing was performed during the tachycardia. Subsequent to that, there is narrowing of QRS. There is a change in the QRS morphology is noted, which is unlikely with SVT with aberrancy or pre-excite tachycardia. On cessation of pacing, the LBBB tachycardia continued, and the first return electrogram of the tachycardia occurred in the ventricle, making the response AVVA, which is very much consistent with the aventricular tachycardia. This happened to be a case of VT from the RV apical free wall. Coming to case 6, a 47-year-old lady was reported to have an LBBB tachycardia that was responded to intravenous amiodarone. Here also the ECG was normal. There was no structural heart disease by echocardiogram. EP study showed normal AH and HV intervals, and ventricular pacing induced an LBBB tachycardia. Coming to the slide, here also the LBBB tachycardia had a one-to-one AV relation and a negative HV interval that excludes an SVT with aberrancy. To understand the mechanism, a premature atrial extra stimulus was delivered during the tachycardia. Subsequent to the extra stimulus, there is actually the HH interval, the VV interval, and the QRS morphology remain unaltered. That is, despite transiently dissociating the atria from the circuit, the tachycardia remained unaffected, thereby excluding a pre-excited AV re-entrant tachycardia. So this happened to be a case of ventricular tachycardia from the posterior-basal RV free wall. Now coming to the last case, a 50-year-old lady was reported to have an LBBB tachycardia that was terminated with the intravenous adenosine. Total ECG was normal during sinus rhythm. There was no structural heart disease by echocardiogram. EP study showed normal AH and HV intervals. Retrograde study showed concentric activation with the decremental conduction. Anterograde study showed dual AV node physiology as well as pre-excitation with incremental atrial pacing. The LBBB tachycardia induced in the EP lab was confirmed to be atriovascular re-entry. A narrow complex tachycardia was also got induced that was confirmed to be typical AVNRT. During one of the occasions, an interesting transient phenomena was observed. So this trace actually shows groove beating involving 3 distinct QRS morphologies and 3 distinct intervals. The first fully pre-excited beat with a negative HV interval, and the distinct RV apical activation preceding the basal His activation is actually an atriovascular re-entry. The third narrow QRS beat is actually a nodal beat. The second fused or incompletely pre-excited beat with a positive but a shorter HV interval with his electrogram slightly preceding the ventricular electrogram is a pre-excited EVNRT beat. So on the background understanding that the patient had an intravesicular re-entry as well as a typical AVNRT, this happens to be a case of trigeminal tachycardia with a sequential occurrence of intravesicular re-entry beat, pre-excited AVNRT beat, and a typical AVNRT beat occurring in a trigeminal fashion. With that, I'm concluding my talk. Thank you for the opportunity.
Great presentations as usual, KK, but just a comment that when you talk of all the maneuvers which you very well presented, and I think that there are hardly any maneuver that's left after all those 6 or 7 cases on how to differentiate pre-excited or a wide chorus tachycardia with atrial and ventricular pacing maneuvers. My only concerns are with 2 cases where the His electrograms are not clear. Once the His electrograms are not clear or not recorded, then all your presumption on maneuvers go for a 6, are no longer valid. That's my personal feeling. That then it could be, you can say whatever is happening. I think there was a case 2 where there was no His, and I think atrial extra stimulus brought in the tachycardia, but I don't know whether this was the one.
Yes, sir.
Yeah. And so yes, the atrial extra stimulus pulled back or decreased the tachycardia cycle length.
And Mohan.
And on the basis of that, you said it is atrial tachycardia or something, is it?
Sir, actually, the atrial extra stimulus has advanced the ventricular electrogram with by advancing the septal A interval. That is the atrial electrogram in the His channel. Assuming that it is at the His anatomical region, it got advanced. So that means the anterograde conduction of the route of transmission of the atrial extra to the ventricle through a node. So that is anterograde conduction is happening through the node actually. So that practically excludes a pre-excited re-entrant tachycardia. And the atrial extra advancing the V without any change in QRS morphology actually that points against a ventricular tachycardia or a pre-excited tachycardia with the bystander pathway activation. So the atrial extra advancing the V with a change without any change in the QRS morphology is a point against a ventricular tachycardia. The atrial extra advancing the ventricular electrogram preceding the with the prior advancement of the septal atrial electrogram is a point that the anterograde conduction has happened through the node. And then lastly, the VA interval, which is preceding the delivery of the atrial extra, and the VA interval which has happened after the delivery of the atrial extra, they are distinct. That actually shows absence of VA linking. That's why I postulate that this could be atrial tachycardia.
Yeah,
Mohan,
till that moment where you have a VA delinking, this could be anything that comes down the AV node. But that presumes that this is a His bundle.
Yes.
This is a septal atrial electrogram. That's it.
Yeah.
Because this could be anywhere in the septum.
Yes, sir. Yes,
and you're pre-exciting the septal atrial electrogram. And I was just wondering whether this could be just atrial tachycardia, or it could be anything that comes down the AV node. And VA linking might have had some importance in terms of differential diagnosis, but VA not linking on a tachycardia which advances with atrial extra has little diagnostic value. That's what I feel. I mean, it's well taken that this would be taken as an atrial tachycardia, but this could be AVNR.
Can I add to what Mohan is saying?
Yeah, sure.
Yes.
I had similar concerns, Mohan, and of course I think the way you have presented in the spectrum is amazing, and everything is backed up by a fantastic publication, which is great for our country. But this same case, if we can go back to the same case, in AVNRT, for example, you can have all types of VA times. VA time can keep changing, the AV time can keep changing, and for the purpose of argument, as Mohan said, if you don't have a his bundle recording, then can you rule out just because of septal A, even we assume this is a septum, what about a nodovesicular or nodoventricular bypass tract? Could it not come earlier with an earlier A wave?
Yeah.
It may not be atriovesicular, but what about a nodoventricular?
Yes, sir. Basically, yeah, I agree, sir. With the nodovesicular, with the nodoventricular, this can happen actually. The septal A and the septal A advancement can occur. In that case, the septal HH will remain the same. So APC, septal HH advancement, septal A advancement, then V advancement favors nodal conduction, delivery of the APC. Then after that, the septal HH remains the same, and if the septal A advanced, that is actually classical of nodoventricular. So advancement of septal A without advancement of septal H, it actually favors nodoventricular. So lack of his electrogram is definitely a limitation in this case. Agree, sir.
Right. And I think a similar thing happened in case number 5 or 6, where the electrograms were not, because again, I'm just coming back to being a kind of purist for these things. I'm sure whatever you've done, but the speed with which you have gone, we need to understand how you came to a conclusion without the his bundle electrogram being there. Yeah,
so
this
basically,
seems to be all right. But even here, yes, it narrows with atrial pacing, no?
Yeah, it narrows with atrial pacing, sir.
Yeah, and what happens to the AH during that narrow pacing or the HH? You don't know.
We don't know, sir.
So we presume that this that is occurring with a faster rate is through the node, although there is some aberrancy. And then the background rhythm is something that is purely ventricular. Is that right?
Yes, sir. So basically, the tachycardia was going on. I had paced the atria. So with atrial pacing, what happened was there was a narrowing of QRS or normalization of QRS. And on cessation of pacing, there is resumption of the LBB tachycardia. So yeah, this when you're actually, if it would have been an SVT with aberrancy or a pre-excited tachycardia, once you pace the atria at a faster rate, the narrowing of the QRS complex is less likely, sir. That's what I think.
Yeah, but you could still technically have a nodovesicular tachycardia, which for some time you suppress or start capturing through the his and the QRS narrows and goes back as nodovesicular once you stop the pacing.
So yeah, in that case, the first return electrogram will actually appear on the A, sir. Here basically, since the onset of origin of tachycardia is actually from the B, the first return electrogram on cessation of pacing actually in this case appeared on the B. That is the ABVA response. So this ABVA response on cessation of pacing is more favoring a ventricular tachycardia, sir.
But it would be the same in nodovesicular.
And
Mohanan, ABVA response.
Mohanan, just for the sake of argument, again taking on from where Mohan left, what if it is a 1:2 conduction with the last beat? I say it's a 1:2 conduction with you don't have a his electrogram. I say it's a 1:2 conduction. You're pacing fast, so it blocks in the accessory pathway. And when you stop pacing, it goes through the AV node and then goes slower through the accessory pathway, 1:2.
Yeah, you meant to say it's a pseudo ABVA response.
Yes.
You meant pseudo ABVA response, sir?
Yeah, yes. Yeah, something like that. I mean, you can call it whatever you
actually,
want.
It's this beat is this beat is actually linked. You have to see like which beat is linked to this which beats are actually. So this is the last atrial paced beat, and the ventricular electrogram that is linked to this beat is actually this one. You can actually see.
No, I don't mean a pseudo. I don't mean that way. I mean a 1:2. The last atrial beat has double conduction.
Okay, sir. Wanted your response. Okay. Yeah, the first beat is nodal and the second beat is tachycardia. Second beat is Second beat is through the yeah, possible, sir. Agree.
Yeah, but Mohan,
No, I don't think
your
so.
point
They
regarding
mean
I don't
dual
think
slow
so.
pathways. They mean dual slow pathways.
So, but the
I
only thing is,
think Dr. Ajit is trying to say
yeah,
something.
see,
One second.
the point that Dr. Krishna has made, that if we spacing the atria and it is narrowed, it shows a narrow QRS, which
Right.
is certainly not likely to happen with an pre-excited tachycardia, which has a atria as a part of the circuit. So that is clear. The second part, of course, is this response to VA. A V response is certainly favoring VT. The point regarding what Mohan said regarding whether it can be atriovascular, it is also a possibility. Certainly, it cannot be rolled out, but you will have to bring in other factors to roll out. And so, not atriovascular, nodovascular.
Yeah.
Yes. That needs to be brought out with other techniques.
No, I think, in my opinion, this tracing is actually very diagnostic of a ventricular tachycardia. If what Dr. Yash is saying, if you think it is 1:2 in the last phase beats, then the return beat is A, and then it cannot come back to with such a short PR interval with the wide QRS. So this, in essence, is VT. If you have a wide QRS rhythm tachycardia, you pace the atria and you narrow the QRS to a normal QRS with a AVVA response. This has to be VT. It can't be anything else. Just like an atrial tachycardia, when you pace the V faster, you get VAAV response. So it has to be atrial tachycardia. So I don't think this one as an issue. But what I would suggest is, though these, again, as Dr. Yash said, wonderful presentation, wonderful cases, and wonderful publications, but to present all these cases simultaneously, it's actually too much for, and even for a very experienced DP to handle. And the only thing that was missing in this presentation was possibly a bundle branch reentry VT. And even in the diagnosis, differential diagnosis that you mentioned initially, you can in fact further down your VT into myocardial VT,
yes,
bundle branch reentry VT,
yes,
and interfascicular reentry VT. Though LBVP will not have interfascicular reentry VT. Similarly, the same thing, that atrial extra, advancing the V with the same morphology, again you can exclude myocardial VT, but it may still be a bundle branch reentry VT, as in your case number 2.
yeah,
But
yes.
yeah, but
The only additional thing that can be added is an nodovascular, which could also show a left bundle morphology, which he has not shown. But that is often with an VA dissociation, but it can also have with 1:1 VA conduction.
Agreed.
Yeah, so I think there's some comment. Let me just go quickly to the comments. If I said, why not just overdrive suppression without entrainment by atrial pacing? I think that's precisely what Krishna Kumar was trying to say. Again, if I were to summarize, I think that you presented beautifully how in a wide QRS, atrial pacing and ventricular pacing and response to atrial and ventricular pacing can help to differentiate the different levels at which these wide QRS tachycardias can occur. But again, I would think that a lot of these maneuvers are dependent on what happens, or what is the relationship of the premature complex to the his, and what happens to the his in response to the. So my only concern, as in the beginning, it's not at all. I wouldn't dare, or I would not never try to contradict what KK or Ajit are saying. But I think that it makes it a little less convincing when there's no his electrogram in these maneuvers.
Yes, absolutely, Chris.
Yeah, there's some other comment. Let me just see. HV interval in bundle branch VT is longer, and nodoventricular is negative. Okay. No,
Usually this.
again,
Sir, can I make a comment, sir? Usually this bundle branch ventricular tachycardia is very fast, and usually they are hemodynamically unstable VTs. So in the EP lab, it is very difficult to perform maneuvers. There are only, if you're lucky enough, basically we'll be able to demonstrate VA jump with induction of tachycardia.
Also,
but otherwise,
if I remember from the Wisconsin group, they were not maneuvers, but they were just seeing spontaneous changes in HH and linking it to changes in BB rather than maneuvers. Correct me if I am wrong. I mean, Masood Akhtar's first article on bundle branch reentry, there's no maneuver, you know, they just were looking seriously, and what Krishna Kumar says is right. It's almost impossible to do these maneuvers when these VTs are going on. But if you then look at the tracings, the VV are linked to changes in HH, and that was the first most important diagnostic criteria with a underlying bundle branch black, and at that time, of course, a substrate of myocardial dysfunction. Is that right, Krishna Kumar?
Yes, sir. Yes, sir.
I think what is amazing is one center in 1 year has 7 publications in fantastic journals on LBBB tachycardia, all with different maneuvers. I don't think any, even the Mayo Clinic or even Sam Asirvatham would be capable of this. So I think hats off to you all, Ajit.
Yeah, that's
agree.
wonderful, actually. Absolutely wonderful. In fact, like Kartikeya said, for some of us lesser mortals, it might have been too much. And I would love to go back, you know, and maybe over a beer, go back on each of these tracings to really understand, because my RAM, rapid access memory, is not good enough to have 7 bundle branch reentry tachycardia being presented in 30 minutes. So, but yeah, absolutely hats off to the Sweetita team.
No, so your next task, KK, should be to write an paper on how to approach a patient with LBBB tachycardia. And you can give all these examples and all your references.
Yeah.
Then we can all read it slowly over a glass of beer.
Maje mein, you know, chai pe charcha kind of thing. Not a webinar pe charcha. Both ho gaya, you know. I mean, I didn't know where the QRS was moving when his slides were moving.
That's why you couldn't see any his, you know.
Yeah, actually there wasn't. I was glad that there wasn't a his, because if there was a his, I wouldn't have seen it anyway.
So I think we can call it a day then. What do you say?
Yes.
Are there some comments, Vanita, just see on the chat box that we need to address?
Dr. Yadave has a couple of comments. He says HV interval.
Actually, can I make just one comment?
Yes.
This term duodromic, you know, that we are using in India. One of the publications I had sent, it was sent back saying that we should not be using this term duodromic. It's quite non-specific, but I think it's quite easy to understand. How else do you describe a tachycardia where there are two? English-wise, it's wrong. Duodromic doesn't make any sense. What are you trying to say by duodromic?
Both anti and
yeah, this term is only.
No, I think this term is only who sent it back to us.
One at a time, please. One at a time, please. Dr. Ajit, please, you were saying something.
I think what he said is correct, that the duodromic once sent, I think Prastowski sent it back. Dr. Shomar will, KK? He sent it back saying this duodromic is a very odd state, so you got to change it.
Dr. Yadave, you were saying something?
Actually, the term used to be pathway to pathway mediated tachycardia.
Right.
Correct.
That is the more common. It's duodromic, I have heard only in India.
Duodronic, actually. The drones coming from both sides. Anyway, nice end to an evening where we unfortunately have lost the first one-day international. So once again, thanks for cheering us up with some great cases. Both Padmanabhan with his wonderful compilation of COVID, and KK and Ajit as usual with a fantastic bundle blanche LBB morphology cases. And thank you, Yash and Dr. Vanita, for bringing it together.
Thank you, sir.
Thanks a lot. And we come to the end of this evening. We'll get together again on next Friday. Please mind it. Friday, we are going to come together at 7 p.m. because it is a mini symposium that we are going to have. It has been pre-decided. It is going to be a mini symposium on physiological pacing versus CRT. So we're going to have good discussion. So please be there. Thank you so much and good night, everybody.
Thank you.
Thank you,
I
madam.
think
Stay safe.
I think Issa